everybody. This is Mirvat Alasnag with CCI Journal, and with us today is the editor-in-chief, Dr. Stephen Bailey. With us is Dr. Morton Kern, the director of and moderator of our case report roundtable. Today we're going to be discussing an interesting case where shockwave lithotripsy was used to treat calcific mitral stenosis. We have a team consisting of Dr. Neil Pham, Dr. Sami AlNasser, and Dr. Abdulaziz AlShaibi. I'm going to hand over to Dr. Morton Kern to go ahead and lead the discussion today.
Good morning. This is Morton Kern. I'm with Dr. Steve Bailey and colleagues here. This looks to me to be one of the most exciting and innovative approaches to mitral stenosis ever. And that, of course, it's in our new era of structural heart disease. So what I'd like to do is welcome the case presenters, have them give us a couple of minutes of their findings, and let's discuss what the results were and what this means to us.
So good morning, everyone, and thanks for having us to discuss this case series that was published last month. So this case series tried to address the feasibility as well as the safety of a balloon valvuloplasty along with a shockwave lithotripsy in the treatment of calcific mitral stenosis. As we all know, balloon valvuloplasty has been around to treat traumatic mitral stenosis, but the utility of balloon valvuloplasty for non-dramatic and calcific is not well established. In fact, not recommended in the guidelines. However, given the new approaches to mitral valve, specifically the presence of calcium modification therapy, including shockwave lithotripsy, we thought of considering this intervention specifically to a group or a subset of a group of patients who are otherwise not eligible to have any other interventional therapy. As we all know, the calcific mitral stenosis is quite challenging surgically. Extensive decalcification of the mitral annulus, the surgeons don't like at all, as it increases the chances of AV dehiscence and LV rupture.
We'll focus on the case and some of the material, and then we'll get into some discussion.
Initially with a balloon lithotripsy, followed by a balloon valvuloplasty. And this showed a not only reduction in invasive gradient, transmitral gradient during the procedure, but also on follow-up echocardiography, and more importantly, without significant safety concern. There were no cases of significant mitral regurgitation, and the patient during follow-up did report significant improvement in symptoms, which was one of the important findings of this study. I would just add probably one thing is that this case series is the first case series that looked at the short-term follow-up post this kind of procedure, and also had simplified this procedure significantly compared to prior reports, as most patients underwent this procedure awake under conscious sedation with intracardiac echo guidance.
So give us the duration of your follow-up before we get going further.
The median follow-up was approximately 90 days for the overall cohort, but we have follow-up as long as 1 year for some patients.
Wonderful. Okay, so what was it that in the key aspect of this approach, your figures are well illustrated. You did your pre-mitral stenosis evaluation by CT scanning to look at all the calcium, and on the figure 1 shows very dense calcium in both the aorta and the annulus. And how was it that you selected your equipment?
These patients were initially screened for other therapies, specifically, obviously, surgery and transcatheter mitral valve replacement. And as part of this, or when patients failed to be a possible candidate for transcatheter mitral valve replacement, they then underwent a CT scan for TMVR planning. Unfortunately, in this during these times, the candidacy for TMVR is quite limited, and therefore most of these patients were screen failed the contemporary TMVR platforms. And then we had to use the CT data to plan the valvuloplasty procedure, which I could or my colleague Dr. Fam could go over details. So typically in terms of as we mentioned, the main concern of this population is the high calcium burden, but on the other hand, these patients are very symptomatic despite medical therapy, and that's usually the time when they're referred to have any intervention. And as a result, and given some early report of successful lithotripsy facilitated valvuloplasty, we had considered it in the first patient we've done. Typically, we would, apart from the first patient who underwent the procedure under GA, as I mentioned, all the other patients underwent conscious sedation, where we established a transvenous femoral access, and also a venous access for ICE for guidance. And typically, we will perform a transeptal under ICE guidance. And usually we would perform a lithotripsy. However, before we do that, we would typically ensure a cord or mitral apparatus free path of the wires. And so this is typically done by visualizing the mitral valve on ice. And in addition, if we have any concern at all, we'd also floss the mitral valve with a balloon-tipped catheter. And once we are happy with the wire position, we would then exchange for a coronary wire. Typically, Ironman was the most commonly used in this procedure, and did a lithotripsy using the commercially available balloon sizes, which is 7 or 8 millimeter for preferable balloon. And we would deliver 300 impulses across the mitral valve. I have to say what's unique about this case series and the technique described in this case series is the use of deflectable sheath. So when you compare to other reports, at multiple lithotripsy balloons were used across the mitral valve. However, in our case series, we used mostly one balloon, and the use of deflectable sheath had facilitated the distribution of the impulses across the mitral valve, as shown in Figure 2, by deflecting the sheath and maneuvering the sheath in different direction, whether it's flexion or counterclockwise or clockwise. We could then have the balloon deliver the impulses across the mitral valve, which in our experience was favorable and enabled the use of one balloon, and therefore a shorter and less complicated procedure. And then after delivering the shock wave, we then brought a non-compliant balloon over a safari wire, and the sizing of the balloon, typically we would use an echo intercommissural distance, and if the CT scan is available, we certainly had used that. And as a rough measure, we used 70% of the intercommissural distance for the initial balloon sizing, and then we would go to a larger size, depend on the procedural result, name specifically the mean gradient. And
some of us are not as familiar with the lithotripsy story as you are, of course. So in the initial selection of a lithotripsy balloon, you referred to a prior studies, somebody had done this before. And how did you then decide to do it, or what caveats did you do when you undertook it? So did you have somebody come and show you, or did you go to somebody else's lab and see how they did it? What was your approach to using lithotripsy? I presume these are the first ones that you've performed in your hospital.
So, Marvin Eng from Henry Ford described the first report of this. He took 3 shockwave balloons. They were not delivered through deflectable catheters, and then did the valvuloplasty with a large cylindrical balloon, I think, NewMed or something like that. So our iteration, or our idea, was to improve on this by using a deflectable catheter like an Agilis to oppose the balloon to the MAC. Because unless the balloon is actually in contact with the calcium, I don't think the shock waves travel very far through blood. And we didn't think we're going to actually modify the calcium or improve the leaflet pliability and leaflet motion unless that was the case. So that's what we did. The first time we did it, I think we used 2 Agilis catheters and 2 balloons. The only reason we chose the 7 or 8 millimeter lithotripsy balloon is that those were the largest ones available at that time. But if you think about it carefully, the emitter of the shock waves in the center of the balloon shaft, you actually don't want a balloon that's too large, because then the distance the shock waves have to travel could be potentially larger. So we used the balloons that were available, which were 7 and 8 millimeters, and then deflected the catheter and torqued it posteriorly, which is mainly where the MAC is. Start medial, deliver shocks, go centrally, deliver shocks, go laterally, deliver shocks. Basically, just keep going around the annulus until you ran out. And if there was anterior calcium, then we would torque the catheter counterclockwise and similarly do the same thing. Very well tolerated. It's a small balloon. It's not causing any obstruction. And in a subset of patients, which is perhaps the most interesting thing, we did see the gradient come down a few millimeters of mercury prior to actually doing the large valvuloplasty, because I have been asked by multiple people, and rightly so, is it just the valvuloplasty that has the effect with your 28 or 30 millimeter new med balloon, or is it in fact the lithotripsy doing anything? But in a subset of patients, we certainly did see a reduction in mean gradient by 3-4 millimeters of mercury.
So on average, you would say that this calcified annulus, if you had not used lithotripsy, you may not have been able to get a reduction in gradient.
I think we would have seen a reduction. The one of the outstanding questions here is, how durable is this, and will you have restenosis? And I think we have seen some cases with restenosis at late follow-up. So we're using a balloon which was designed for peripheral angioplasty, femoral iliac arteries, versus for a valve application. And I believe the company is working on, purpose-designed lithotripsy balloons for valvular calcium.
Yeah.
Yeah.
Do you think this would have facilitated the implant of a catheter mitral valve?
I think that it would. And actually, I know some people have already done that. They've used exactly this technique to modify the calcium, to open up the annulus a bit, and then implant valves, with the idea that perhaps there'd be less PVL. And it's also been used in the aortic valve, for example, in high-risk bicuspids and this type of thing. But these are all anecdotes and case reports, and I think Sami led this experience with 15 patients to provide some kind of a case series and some type of at least short-term follow-up to say it's feasible and safe. The question is it durable? But as we mentioned in the paper, these patients are very desperate, have no other options, are highly asymptomatic. So the fact that you can offer them something that is safe and what appears to be reproducible, I think, is a little beacon of light for these patients.
Right. Do you think there's any advantage to finding some way to push the lithotripsy balloon against the calcium rather than just deflect it into the calcium? Would it be more effective, less effective, if you had such a concept?
Yeah, I mean, from my mind, as long as the balloon is directly opposed to the calcium, it's gonna the shock waves will actually reach the calcium. Whether or not you can debride the calcium or something more eloquent with a catheter remains to be seen.
Good. Now, were there any complications associated with these procedures compared to others that you've done with similar degrees of calcification?
So we were very worried about stroke, which is why we had sentinel embolic protection deployed whenever feasible. And we certainly captured lots of calcific debris in some cases, but we clinically had no strokes whatsoever, which was very encouraging.
Do you think there is debris released from this technique?
Oh, for sure there is. I don't think we included it in this publication, but I have some pictures of the basket, after, and it's not subtle what comes out.
So, that's different than coronary lithotripsy, to my recollection. That is, we don't release much material. We just crack a dinner plate that's hard calcified material into fragments. They stay in place. they lend themselves to deformation by a balloon inflation. When I think of the mitral annulus, I don't think of material released. I think of that dinner plate cracking, but this is news to me. And I guess using a cerebral embolic protection is pretty key. If you found material in that basket, then people are going to be in trouble if they go do this without. So
many of these patients actually have involvement of the leaflets in the subvalvular apparatus. Was there information that you gained from this patient population about features that you might want to examine with respect to those aspects as well, not just annular calcium?
Certainly. I mean, we got the advantage of the 70% of this group who underwent a TMVR CT scan, and we got an in-depth analysis of the calcium involvement. And actually, we reported in this series that this is not only MAC, because in truth, there's a lot of MAC patients around, and they're not necessarily symptomatic from the mitral valve. It doesn't necessarily cause stenosis. But in this population, 90% actually did involve the leaflets, and they almost 50% did involve the commissure. And for small patients, like two patients did involve the pap muscle, and we had 2 patients who had KCS MAC. And again, for KCS MAC, there's always a concern, at least theoretical one, of the risk of embolization with balloon valvuloplasty. But again, as Neil outlined, there were no cases of stroke with the judicious use of Sentinel in this cohort. As Neil mentioned, we have a follow up to 1 year for some of these patients, and one at least patient with radiation heart disease did have restenosis and required the procedure to be done again. What's interesting is that, as Neil mentioned, this procedure helped these disparate patients and offered them and bought them some time till another maybe TMVR therapy or a progress in the field could become available. For example, in the patient and one of the patients who had restenosis, he did have the procedure twice and then ended up having an alternative, a more definitive mitral valve therapy, which again I think it highlights the compassionate role for such therapy.
So 2 things: how much calcium do I need, and does it matter what balloon I pick?
I think in terms of quantifying the calcium, Myra Guerrero reported 2020 just some objective measures of quantifying calcification. That the score or the max score that she reported was basically to report or to predict the embolization of a sapien in MAC. I'm not sure if it necessarily translates into the potential benefit of using lithotripsy, but in the max score in our cohort was 6, and 7 is usually severe. And I think we were just struck by the leaflet involvement. And this is the patients where, when you look at the echo, it was like the reaction is like, oh boy, the leaflets are just encroached and barely opening. And I think this is the population that we use the lithotripsy for.
I think one comment we didn't focus on too is we did touch about safety, but another aspect we're worried about is the development of MR with valvuloplasty, these highly calcified valves. But again, we've showed trying to avoid like a cord, having the wires not being in between cords, and really focusing with ICE guidance or TE guidance in one patient. You could safely do this with none of our patients had moderate MR or greater. So we can do this relatively safely with no significant MR.
That's a great point. Do you think you would have ruptured a cord had you been underneath it with the lithotripsy balloon?
I don't think the lithotripsy balloon per se, but perhaps the actual valvuloplasty. If you've been
the valvuloplasty, for sure. Okay. Yeah. Well, I think this is a really excellent case, and we should all take heart. And the structuralists approaching mitral stenosis with heavy calcification are going to teach us much more about this as time goes by. So I want to say thank you very much to our presenters, and Mirvat for organizing this, and Steve Bailey for hosting the site on cath and cardiovascular interventions. It's a pleasure to be here.
Thank you everybody for joining us, and we hope you stay tuned for our next episode at CCI Journal.